من الإمارات. And I would like to welcome Dr. Hiba Badri. She's consultant pediatrician neurodevelopment at Al Jalila Children's Specialty Hospital, Dubai. She will present the third session for us. I will allow Dr. Sati to welcome her. Before that, I will start with القرآن الكريم كعادة البرزنتيشنز. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. اقرأ باسم ربك الذي خلق. خلق الإنسان من علق. اقرأ وربك الأكرم. الذي علم بالقلم. علم الإنسان ما لم يعلم. صدق الله العظيم. بروفساتي.
طيب، بسم الله الرحمن الرحيم. السلام عليكم جميع الأطباء الأخصائيين، ولو كان في نواب واستشاريين وغير بيدياتريشنز. مرحبا بكم جميعا زي ما قال دكتور عبد العزيز في اللقاء الثالث بتاع الأكاديميك أكتيفيتيز بالنسبة للجروب بتاع أطباء الأطفال السودانيين. افتكر التو اكتيفيتيز المره اللي فاتت مشت كويس جدا، وهذه المره الثالثه نرحب بالدكتوره هبه عبد الرحمن بدري، نيورو ديفلوبمنتال بيدياتريك كونسلتنت، وان شاء الله تقدم لنا يعني برزنتيشن عن النيوروفايبروماتوسيس. ونتمنى يعني انه كل الشباب وكل الناس الكونسلتانت وكل الناس القدام انه يستفيدوا من البرزنتيشن ده. وافتكر we will get a lot of benefit from this presentation، ونتمنى للجميع انه الاستفادة، وبالذات الناس الموجودين داخل السودان زي ما بيقولوا قابضين على الجمر انه برضه يستفيدوا اكثر، وتكون لهم فرصة على اساس انه تقريبا يناقشوا المواضيع دي ودiscussion و تقريبا to have these cases مع بعض و to discuss it ويصلوا ل تقريبا نتائج كويسة. فمرحب بك دكتورة هبة، ونتمنى انك have your presentation والناس كلهم يستفيدوا استفادة قصوى ان شاء الله. شكرا.
شكرا لك دكتور ساتي، وشكرا للشباب المنظمين. It's one of the greatest pleasures يعني would have في ظل الظروف الناس عايشينها. نقول إن شاء الله البرزنتيشنز الجاية تكون من السودان زي ما كانت عادتنا كلنا كبيدياتريشنز. ربنا يعيد الأمن والسلام ويرجعنا أهلنا ويلمنا في بناء وفي تعمير إن شاء الله. يعني ربنا يرحم دكاترتنا وأساتذتنا اللي توفوا، ويلهمنا القدرة إنه نساعد ونقوم بجزء من الحاجات اللي هم كانوا بيقوموا بها في التعليم وفي التدريب وفي maintaining this chain of progression. يعني الميتينج today يعني جدد لنا حاجات كثيرة وذكرنا بذكريات و very cornerstone memories يعني بالنسبة للزول في التريننج وفي السودان وفي شغله مع الناس هناك. ف welcome all the juniors who are joining us سواء من السودان أو من الفيافي. وإن شاء الله يكون السيشن خفيف يعني عليكم. It's not the commonest of presentations you will get، لكن hopefully it can stir a bit of more discussion for your exams and for your general clinical practice. Anna, if you don't mind, we'll close the video so you can keep your eyes on the presentation. At any time, if you have any question, by any means, put it in the question and answers. And we'll be happy for other people to interrupt if you stop hearing me, or there is any problem with the voice or the connection, just feel free to put it in the chat box as well. And today's presentation is about neurofibromatosis beyond just the Caf'e-Au-Lait macules. It's a topic that is very close to my heart. Why are we not? Okay. So hopefully by the end of the session, we would cover the outlines, including the disease background, the biology, a bit on the basics. How do we diagnose, and what are the common symptoms that you should see? And then how are we managing these cases? And we'll include some of the prospect and the future treatments coming in hand. So neurofibromatosis type 1 is one of a group of distinctive genetic conditions where the tumors tend to grow on the nervous system. And from its name, it's a neurocutaneous condition because it involves the skin and the nervous tissue. There are 3 types of neurofibromatosis. There's neurofibromatosis type 1, which is the commonest, and it affects children, and it accounts for about 90% of the cases of neurofibromatosis, and it is the most common neurocutaneous disorder. And then we have neurofibromatosis type 2 and schwannomatosis, which usually affect adults, and they present slightly different, involving the hearing, so the vestibular schwannomas, meningiomas, and so on. And it's usually not something that you will see in your general pediatric cases. Neurofibromatosis type 1 is also known as von Recklinghausen, where we used to be fascinated with the name and be able to say it in public. It's named after a German histopathologist who was the first to describe the cases in 1880. And he described benign tumors that arise from the peripheral nerve sheath. And this is the first case in literature. And we're sure that this is not the first case ever, because even archaeologists before the best from the Roman and the old Egyptian cultures have identified findings and drawings of individuals we think are most likely have got neurofibromatosis type 1, as you could see from the pictures above. It's a very common disease, though it is still considered rare because it's occurring in 1 in every 2,500. For a rare disease to be rare, or not to be rare, it needs to occur in 1 in every 2,000. So it is still considered one of the rare, though it is the commonest of rare diseases. And it's estimated, according to the Children's Tumor Foundation in UK, that 120 people are born every day with NF1. And that makes it 1 patient every 12 minutes. So you could imagine the burden of such a disease on health systems and on communities. It's an autosomal dominant condition. So 50-50 inheritance if you have 1 affected parent. But a lot of these patients, and almost more than half of these cases that we tend to see, don't have a family history of the condition. And it just occurs as a de novo mutation for them. So your index case is the case that you see in clinic. We know that it's caused by a genetic disease, and the gene for NF1 has been identified in the 1990s on the long arm of chromosome 17. And since then, we've identified more than 3,000 different genetic mutations that have been reported, with missense variants being the most aggressive or linked sometimes to aggressive disease. The gene codes for neurofibromin, and neurofibromin is a cytoplasmic protein. It's important as a tumor suppressor, and it's expressed in your nervous system. So what I tell parents is that every nerve has a sheath, and the sheath is fibrous, and we have a defect in that fiber that makes it grow into tumors, and tumors can be either benign or malignant, and that is what it leads to. If we go back to our biochemistry days, and I'm sure a lot of my tutors and all the doctors from basic sciences would be very upset with me not trying to memorize exactly these details. But I see it as you've got this receptor from the growth factor, and this activates a series of responses for GDP to turn into active GTP. And that is called the RAS system. And the RAS depends on the neurofibromin as the fuse. So if we are having overactivation of that RAS system and more GTP is formed, the neurofibromin turns the switch off. The RAS, the active GTP, activates the MEC system. The MEC system then maintains the cell proliferation and prolongs the cell survival. So by losing the neurofibromin, we have a cascade of non-stop reactions that leads to these cells proliferating out of control and living forever. And that what leads to then the tumors, whether benign or later on malignant. So as I said, it can affect any nerve sheath that is around your body. And the largest organ in your body is your skin, and the most sensitive, and it has plenty of nerve tissue. Then comes the brain and the eyes, but you can find signs of neurofibromatosis anywhere, including your back, your bones, the heart, the gut, and so on. The common manifestations that we tend to see in clinical practice are the Caf'e-Au-Lait macules, and that's why everyone is linking NF1 with Caf'e-Au-Lait macules. The Caf'e-Au-Lait macules, which are coffee and milk colored macules, and it sounds even very nice and fancy, like one of the moms told me. It makes it look like a posh disease. Is easy to identify on fairer colored individuals like my patient here, but it might be a little bit more difficult in dark-skinned people. But I think us being mixed races and different colors and shades of brown, we are more experienced in seeing these Caf'e-Au-Lait spots or macules or bruises on dark-skinned individuals. And it's a skill, I think, very useful when it comes to identifying cases of neurofibromatosis. Then we have the axillary and inguinal frickling. And then the neurofibromas, which are the lumps that are becoming more apparent. And those can grow, again, anywhere, either outside on your skin or inside your body. And they can sometimes occur in the form of a plexiform. So it affects a whole nerve bundle instead of affecting just a small part of a nerve sheath. And when it affects big nerve bundles, it causes a very destructive form of plexiforms that can be quite disfiguring and very obvious to see. So the picture shows you one from the brachial plexuses and the other one is in the leg. And it sometimes can be seen as if maybe this is elephantiasis, but you can see the Caf'e-Au-Lait macules, which sells the diagnosis out. In the eye, we get to see Lisch nodules, which are hamartomas of your iris. And these are not easily seen, so you need a slit lamp exam to see those. And they don't appear straight away. They might appear after the age of 6. And then you have optic gliomas or optic tract gliomas. And as you can see from the MRI below, there is a swelling on the right eye optic tract. The skeletal deformities, very specific to neurofibromatosis type 1, is the tibial bowing. And the bowing in NF is anterior-posterior. So it's not lateral like what you'd see in rickets. It's front to back. And if you can see the X-ray, it's very obvious. It's bent forward. It's not bent to the sides like what you'd see normally. And that's very distinctive. The pseudoarthrosis is like you have an extra joint just in the middle of a long bone. This is one of the cases being prepared for surgery. And this is one of my patients recently operated. And again, you can see the Caf'e-Au-Lait macule being there. And she had a pseudo joint in her tibia, which has been corrected surgically, and she's in recovery, thankfully. Then we have the sphenoid wing dysplasia, which is a very distinctive appearance, usually associated with a plexiform or an optic glioma. And usually it's a plexiform of the optic tract. Very difficult to manage, very resistant to treatment, and very disfiguring for the child and distressing for the family. The common one is the dysplastic scoliosis. The scoliosis usually occur around the teenager years, and it's very resistant to conservative treatment. And the response to surgery has been suboptimal. And they would require rods and corrections and serials of surgeries to manage. Other presentations, as we say, will depend on the site of the neurofibroma. So if it's in the brain, you might come up with seizures and headache. They might have affection of the pituitary, so they will come with a delayed or precocious puberty, short stature. High blood pressure is a common manifestation, either because of vasculopathy or because of the cardiomyopathy it's involved and the intracardiac neurofibromas. Pulmonary hypertension and parenchymal lung disease is also an association. And then, unfortunately, malignancy in different forms, either leukemias, pheochromocytoma, gastrointestinal stromal tumors, and breast cancer can be a presentation. And unfortunately, these cases will come to your clinic as an oncology patient. As I mentioned, during the symptoms, these symptoms will not all be present as we start or when you see the patient first. The most common is the Caf'e-Au-Lait, which can be present since birth. But the rest of the presentations might take time, and some of them are quite uncommon beyond the teenager years. So in their 20s, the neurofibromas, the scoliosis might appear a little bit later. And that is one of the challenges we face, is that how can we make a diagnosis? And here comes my part as a neurodevelopmental pediatrician. I get to see these cases because they're either struggling at school, they've got learning disabilities, or mild intellectual impairment. 30% of them might be on the autism spectrum, 30% might have ADHD and reduced ability to concentrate and focus. And mental health issues related to all of this is very common, especially with cases of plexiform neurofibroma, where there's disfigurement, bullying at school, isolation and depression, sleep disturbances. And a lot of them come with chronic pain, which is the cause of their depression, low mood, or school withdrawal, because they're constantly in pain and they miss a lot of school. This is either in cases of plexiform or scoliosis or because of the headaches, and they miss a lot of time because of their migraines or social of as migraines. The life expectancy for cases of neurofibromatosis is 8 years less than the general population, and that's because of the increased risk of malignancies, high blood pressure and vasculopathy, and suicide, which is a very unfortunate case. And these are the things that we can probably try and avoid and improve the life quality of these patients and their families by trying to intervene, early treatment of malignancies if they happen, good control of the high blood pressure, and support for those with mental health problems. Majority of cases might live a normal life and very productive individuals. Others will struggle with either finding jobs or forming families. And there was a group from Saudi, I remember recently, that they've tried to form a family group of individuals with NF1 to see if there is any chance of them meeting their other halves, because families tend to hide these individuals. It's not easy to find a husband for a girl with plexiform, or people are worried about the disease. So a lot of it is about raising awareness, is about support, and about early clinical intervention. So how can we diagnose? When we were in med school and we were registrars, we know that NF1 is a clinical diagnosis. And that was the case up to the time I was starting in the UAE in 2022. We were all just basing our diagnosis on the clinical manifestation of 6 more Caf'e-Au-Lait macules, neurofibromas, axillary frickling, glial nodules, the optic glioma, the bony lesion, and a first-degree relative. And we did have all of these questions about who is the first degree relative? My brother, my sister, my father, my stepmom, my half brother from my father's side who's got it. Does that count? So who really counts? I've got a grandparent. Is a grandparent a first degree relative or not? So that sometimes puts us in a pickle, and we have unlimited and never-ending discussions of are these patients meeting criteria or not. And one of those examples is this case, a 3-month-old, firstborn to a first-degree cousins. He was referred from pre-immunization examination. He had only 4 Caf'e-Au-Lait spots by the time we've examined him, and there was no frickling. He got seen by the ophthalmologist before he came to my clinic, and they particularly said there was no leash nodules or optic tract abnormalities detected on clinical exam. And there is no family history when we took the history of any NF diagnosis or even hyperpigmentation, anyone who is similar freckles, there was nothing. So if people are still awake with me, do you think that this child meets the diagnostic criteria for NF1? And if so, what shall we do next? I'll give you a minute just to get people a bit more engaged and wake up. I can leave you a little open book exam sort of hint. Okay. So this child does not meet the diagnostic criteria because he only has 4. He doesn't have 6. There is no family history, no other things. So what do we usually do? In similar cases, we would have just said to the parents, we don't have enough. He doesn't have NF1, but on the other hand, he might develop NF. So we would usually ask them to come back for annual reviews just to double check that by next year and then the year after and the year after, whether the child meets the criteria or not. So we don't leave them completely out of our follow-up. And that on its own is a challenge because families are either very anxious and they will go and see other doctors and doctors after doctors because someone is there and they are spending a lot of money on different clinic consultations, or they would just give up and say, well, the doctor said they don't have it, and they will just go away. 50% of the cases will meet the diagnostic criteria by the first year. Well, 100% of them will meet the diagnostic criteria by 8. So we have 7 years in between for these 50% to be captured. The other feature, yes?
In the discussion, they wrote in the chat, as you said, they are not meeting. No, they don't meet the criteria for the answer of question 1. Regarding question 2, some people said need close follow-up, wait and see, and other people, they suggested genetics.
Yes, that's very good, because that takes me to my next, because probably the ones who said wait and see are our generation, because this is what we said. But the wait and see or watch and wait approach brings a lot of parents' anxiety. So in 2021, 90 experts joined up and decided they're going to change the diagnostic criteria. And they came up with these new diagnostic criteria. I've tried to highlight in green those that are slightly different than the previous ones. And when you can see, it is the same, but instead of a first degree relative, now we are specific to a biological parent. Not a child, not a grandparent, just a parent. And then we've added the anterolateral bowing to the distinctive osseous lesions. The leash nodules are now 1 point, and the optic pathway gliomas are a separate criteria. So if you have leash nodules and optic tract glioma, you meet the criteria. Then we have the most important is the number 7, which is the heterozygous pathogenic NF1 variant. And here comes the role of genetics. Despite that we know about the NF1 gene from the 1990s, we still did not include it in our diagnostic criteria. I'm going to put our first line in the hospital and second line for genetic testing. So the first line is the next generation sequencing. This identifies 90% of cases of NF1. And then we have the MLPA, which is the deletion duplication analysis, and that picks up the other 5%. So we might have 5% of cases with NF1 who have a negative genetic test. And those will meet the diagnostic criteria eventually if they are NF1, but they will have a negative genetic test. And the variant that is useful in where we use the genetic testing is like in the patient that we've just discussed, where the child only has the pigmentary features. Is this just a normal birthmark or is this NF1? And if they had a negative genetic test, it makes it very unlikely that this child has NF1. And in that case, we can assure these parents that the child is absolutely fine. There is no need to concern and there is no criteria and no need for further follow-up. So well done for those who put genetic testing as an option. So what do? We've diagnosed someone with NF1. The management involves regular reviews, regular follow-up, so we can early detect complications and we can manage them in a timely way and we can avoid further problems. It's easier to remove a small tumor that is let's say like an olive size than to remove something that is like a baseball. It makes it very difficult. You'll have more symptoms, more side effects that will occur. And if you leave the small lesions for longer, you can then have to deal with the big side effects and consequences. So having an early detection helps with the management, helps with symptomatic control of blood pressure, pain, giving treatment for controlling puberty, either in those with precocious or to help them go into puberty in those with delayed. You have regular monitoring of their growth, management of their pain, support for their psychological well-being, support at school. Surgery can be offered in some cases, chemotherapy and radiotherapy for those with optic gliomas where we are worried about the vision and the vision is deteriorating. And the most important is approach to support, either financial or social, and then the multidisciplinary approach, which is a cornerstone for the management of these cases. They're very complex. They have impairment in different places. It's not good for them to go to a surgeon and then next day they need to go to a psychologist. Then they need to see a developmental pediatrician. Then they need to see an ophthalmologist. Having that MDT or the multidisciplinary team helps smooth these cases and detect the problems as early as can and approach in a professional way. This is a suggestive surveillance that we do annually for children with NF. And this has been adopted from Manchester Children's NHS Foundation Trust from the NF specialized clinic. But because we are in the UAE, different places have different capabilities and access to facilities is different. Genetic testing is offered for free for our patients who are nationals. We can easily do annual and sometimes more than annual MRI scans. And we adopted bone age measurements as an early detection for pubertal status. So you can do what you can do, but the most important is having that regular check of growth, measurement of the blood pressure, checking of the eyes, and then evaluating how the child's mental health and development is going, including any signs of autism, ADHD, or school difficulties that are encountered. When you diagnose someone early, yes, we can intervene and approach better, but for the families, an early diagnosis can help them plan for the future and have other children who don't have IVF, don't have NF. We can get them involved in support groups. We can assure them if they don't have it, and we can get them a bit more involved in research. And maybe we can have an answer when we collaborate these joints together. And there's a lot of support groups for patients with neurofibromatosis or brain tumors that are in the UK, and they're open for members around the world. It's very good, and they have a lot of very good materials to check. Another break. So this is Jumea. She's one of my lovely patients in clinic. She's 5-year-old, referred to neurodevelopment because of suspected learning difficulties. She wasn't performing as well at school. She was not focusing. And they suspected that she might be ADHD. I've offered appointment when she was 5, but they've missed few appointments. And then the mother attended the initial appointment alone because father has been away working shifts off-site. Mom at that time was 30 weeks pregnant with twins, a boy and a girl. Mom and dad are not related. That's from the history point of view. Then I examined the child, as we do with every child presenting with a neurodevelopmental condition. And I could see that she's got 8 Caf'e-Au-Lait macules in different parts of her body. No cutaneous manifestations otherwise, no frickling, no neurofibromas. I've asked my fellow colleagues in ophthalmology to quickly just give her a look if they could see any leash nodules, and they couldn't, despite she was 6 at that time. No skeletal deformities, no scoliosis, no other dysmorphism. She's a very good-looking young lady. And there's no family history of NF, but mom has only just heard about it when I've mentioned it to her. She said she doesn't know what that means. So I said, do you have anyone with similar freckles or anything like that? She said, yeah, she's just like her dad. Her dad has similar birthmarks. And then when we asked about epilepsy or seizures or anything like that, she said, well, her dad's sister is in the States because she's had seizures and they think there is something growing in her brain. So that raised alarm bells in my case. And I was like, where should I go with this? She has Caf'e-Au-Lait macules. She has mild, probably ADHD or learning difficulties, but that still doesn't meet the criteria. So what are we doing next? I'll give you another 1 minute. This is a quick one. Mohammed, feel free to stop me when you've got enough responses.
Okay. So they are saying genetic testing. More of them, they are saying genetic, targeted genetics.
So people have been listening.
One answer is MRI.
MRI.
Brain and genetics.
Mm-hmm. But she doesn't have any seizures. There's nothing to make you go for an MRI brain at that time.
Echo.
Echo.
Mm-hmm.
I would go with the majority who said genetic testing, because we need to establish a diagnosis. Is this just learning difficulty and ADHD, or is this something more? And it's a bit fishy that the dad has birthmarks and the auntie's got something as well. So we've done the genetic testing. And the genetic testing came back positive for a pathogenic variant in the NF1 gene. And following that, we counseled the family on the diagnosis. We've offered target testing for the parents and for the twin siblings. The father and one of the twins, the girl, tested positive. So the father and the brother who tested positive have been attending regular reviews. The father with the neurologist, and the younger brother has been in my clinic as well. She has been doing fine. She's in school. We've offered her inclusion support. She didn't reach the threshold for ADHD, but she does have mild learning difficulties that have been well supported. Father was still reluctant to mention the diagnosis to his sister. And I was very positive about the system might have NF1. And if someone did not pick that in the States, I would be really disappointed. He was very reluctant to share that news with the rest of his family. We've offered family counseling and IVF and pre-implantation genetic diagnosis. And they've took the offer. And the last time they visited me in clinic, they had a 3-month-old who's thankfully unaffected. The family have been stable, no severe situation, no significant symptoms up till now. And parents have actually been very active members of our NF parent group. And they spoke in conferences and helped in counseling other families with the condition. I will focus the coming 5 minutes on a bit more distressing cases that you might be seeing في السودان بالذات of plexiform neurofibromas. As we said, surgery is the first line if it is in a place where surgical management is amendable. And you could see this one had a large plexiform on the buttocks that been surgically operated, and it's a common site. And that was removed after a series of surgeries. They've managed to come to close to normal. The problem that we have is that depending on, it's very vascular, there is high risk of bleeding. It depends on the size of the tumor, its location, and the risk of recurrence, because after surgery, a lot of them will grow back. So what shall we do with the others? They've tried looking into it because it's a very distressing condition. They've tried radiotherapy, chemotherapy, and that seems to have very minimal effect. And then the whole research era started being focused on novel treatments and targeted therapy. And in 2000, in April 2020, we got the first medication approved by FDA, sunitinib, to treat NF1 plexiform. And it works by blocking the MEK. So if you remember the cascade of change that we spoke about earlier, in this case, we don't have the neurofibromin, we don't have the fuse that will stop and the cascade, but the medications, the sunitinib, work on inhibiting MEK. So it stops the cascade of reactions, and it stops the never-ending cell proliferation. So it's not a complete replacement of neurofibromin, but it tries to put a plug or a stop further down the line. It's indicated for children age 2 up to 18 with NF1 plexiform that is symptomatic and inoperable. So it's very specific to when it can be used. It's in an oral form, so there is a 10 milligram, there is a 25 milligram, and there has been quite a significant reduction in the size of the tumors after 2 years of receiving sunitinib. And a lot of these children will report less pain when asked compared to when they started. It is a very expensive drug. It costs about $15,000 to $22,000 per month. So it's not a cheap option, and we have to be very selective on which patients will benefit from it or not. The patient on the picture is a patient on sunitinib with a plexiform of the neck. It's very difficult to operate because of the vascularity approaching the trachea and other main structures. So they decided to start him on sunitinib. And from reading from the literature, he started presenting with sleep apneas and difficulties in breathing. So sunitinib helped this child greatly, and without needing for surgical, it improved the quality of life, it improved his obstruction, the pain, and we are approaching normal appearance by 37 cycles. And the cycle is 28 days, and it's a continuous medication taken orally twice daily, every day. It has minimal side effects, usually affect paronychia, skin rashes, and we need to check the CPK for the heart functions. then a next contender, and I like it when there are contenders, especially when it's people are competing for patients' benefit. When you have one medication, the price is high, only limited people can have it. Then you have another and another and another, and the competition is in the benefit of the patients, because we'd assume that with time the price will drop and more people can make use of this medication. The mirdametinib is FDA approved last year, end of 2025. It provides alternative for adults, because remember, sunitinib was only for children 2 to 18, but this has been used in children and adults. Has better compliance because it has 3 weeks on treatment, 1 week of treatment. And then they develop a dissolvable option. Remember, sunitinib is in capsular form, and it might be difficult for the younger ones to have, or those with neck or swellings to swallow it. And it becomes much easier when you have the dissolvable option. Price-wise, unfortunately, up till now, it's not much different than sunitinib. It's almost the same, though some initial studies are providing evidence that it might be more effective than sunitinib in reducing tumor sizes. Sunitinib have not stopped. They have ongoing trials to see if they can be used in adult to get the FDA approval, and to be used in recurrent and refractory low-grade gliomas, which are a common manifestation where we are stuck and we don't know what else to do. It's not plexiform, but it's an optic glioma. So these cases might boost sunitinib situation and create, as we said, a healthy competition. People ask all the time about gene therapy. And there is a lot of research going, but with very limited promises of a treatment, because we have little group of patients. Genetic testing is not widely spread, widely used, and we don't have enough sufficient data to tell us which genes specifically to target. And remember, we have more than 3,000 gene mutations of different types. So when we are trying to design a gene therapy, you need it to be very targeted to a specific gene mutation, and that makes it extremely difficult. And we don't say never, never, but it makes it really difficult to find a solution soon. We'll have to brag a little bit about our service. It's the first service in the GCC, started October 2023. It's run by myself and a genetic counselor for the first patients. We offer screening, surveillance, and family counseling. The complex cases that have more than one, we say, system involved usually get discussed in the NF-MDT meeting. And we are lucky in Jalila to have all the subspecialties that we need under one roof. And even those that we don't have, like the dermatology, who is our newest addition, has joined from a sister hospital, and they joined our monthly meetings. Just to mention to my team, I'm very grateful for their existence and for their great support for the service. We've been running for almost 3 years now, and we have more than 100 patients being referred to the service up to date. So it's a great effort, joint effort. And one of the other important achievements from it and from our celebrations of the NF Day is that we formed the first NF parent support group, and that started with only 3 ladies that we've helped form a WhatsApp group. And then the year after, the group has grown significantly, and it's been offering a lot of support and organizing a lot of events for the family members. And it's a direct helpline for these families. We've participated in campaigns, including our parents, and we're trying our best to spread the word about NF and about our patients and our lovely families. And we continue to grow, and we continue to learn. At the end of the session, there are a few take-home messages that I would want to emphasize, is that NF is a progressive, unpredictable, completely unpredictable disease. It can range from mild to life-threatening. Every case of neurofibromatosis is as unique as the person that has it. No one is the same. Even those coming from the same family can present completely different despite having the same gene mutation. It may take one person to diagnose, that can be yourself. To manage such cases, you'll need a team. So you can't do that alone. Early intervention is a key, and the support improves your long-term outcome for these cases and their families. Thank you.
Thank you so much, Dr. Hiba Bedri, for this nice, informative, organized talk about neurofibromatosis type 1. Dr. Muhammad Zain, please go for Q&A. And if anyone have question, can raise his hand. Thank you.
Okay, Dr. Sati, if you would like to comment.
طيب شكرا جزيلا دكتورة هبة. Really it was a very fantastic presentation. We got a lot of benefit and information from that, and really it is really very nice. I have two queries concerning these fibromas or tumors which come as presentation in the patient. Later on, they said some of them become malignant. As a management, if they are removed so early, we try to remove as much as possible of these fibromas or tumors, will it reduce the prognosis that it could be malignant, or will benefit on that or not? The other questions, presence of Caf'e-Au-Lait after birth immediately, the number, had it relation to later on, will this patient will have fulfilled the diagnostic criteria? Will it increase later on, or it is the same number? Will it have a real prognostic presentation in this patient or not? Thank you.
Very nice questions. I'll try to start with the Caf'e-Au-Lait macule ones. You could have Caf'e-Au-Lait macules at birth. The number increased by the visit. So like in the example, that child had 4, but when we examined them a few months later, they've reached the 10, and they will increase with time. I think that is the constant feature when you ask people coming to the clinic. Any new skin manifestations, they will say we just have more freckles and we have more Caf'e-Au-Lait spots, and then parents stop counting them because they know we've just passed the 6, so it doesn't really matter. We don't tend to remove, from a prognostic point of view, it doesn't carry any prognostic value. So those with early Caf'e-Au-Lait doesn't mean that they will have worse disease. Those with more neurofibromas means that they will have a less drastic disease. There is no link between the two. In regard to the neurofibromas, there is a risk by the age of 20 that they have a higher risk for peripheral sheath tumors. And these are quite serious malignant tumors, difficult to manage. But we don't tend to follow and pick every neurofibroma. So we tend to watch and see these neurofibromas, and a lot of them will remain benign. So the only indications for them to be removed, as per our plastic surgeons, is if it is in a place that is causing friction, constant friction, and usually it's your the panty line or in the axilla or next to your watch in your wrist. These places where there is constant friction and it's causing discomfort, we would remove. And if it is growing or the skin over it's changed color or it's rapidly growing compared to the previous, then yes, they will be removed. If they remain the same, we will just leave them as it is and we'll just monitor. A lot of parents will remove ones in the kid's face because of cosmetic reasons, and that's another one. We're trying to look into the use of laser therapy for removal of hyperpigmented Caf'e-Au-Lait macules from the face. We had a girl struggle big time with anxiety because of her freckles. She's has the longest fringe I've seen just to cover her eyes because she's covered in them. And that girl we are considering laser therapy for. But it is important to keep an eye and monitor, and that's why surveillance and regular reviews are important. Hope that answers your question.
Thank you very much. Okay.
We have one question from Dr. Rita. She is saying many children came with learning difficulties, and we used to refer them to the neurodevelopmental clinic. Should we refer to the genetic clinic as well?
Well, in my setting, I'm the one leading on it, but it doesn't mean that every case with neurofibromatosis needs to be in a neurodevelopment clinic. Sometimes it's a neurologist who sees the patients. Like in Manchester, it's run by one of our seniors who's a neurologist completely, but has interest in NF1. So if you have a specialized service, I will say yes. If you have a geneticist who is interested in neurofibromatosis and have a specialized clinic, then yes. But it just depends. A general pediatrician like yourself might be able to diagnose and take over those cases. So it just depends on the setting you are in. A lot of our settings for Sudan, masalan, will not have a geneticist, and access to genetic testing is very limited. Even in third world countries, it's not readily available for people, and it's quite expensive. So it depends on the setting and the availability of services. But I would say a general pediatrician with interest and who've listened through the talk, hopefully is going to be able to pick up and diagnose these cases.
Okay. Next question, Dr. Saeed Sheikh. How to treat ADHD in neurofibromatosis?
You'll treat ADHD in NF the same way, and they respond the same way to medications, behavioral interventions as our first rule. And for medications, they still respond to methylphenidates and to the other treatments the same. But you have to have a closer eye on the high blood pressure, because we know ADHD medications are linked to hypertension in a minority of them. So they just need a good pre-medication check, especially for their cardiac functions and ECG, and then close monitoring of the blood pressure. But they respond similarly to the other children. Behavioral interventions and learning support usually is very useful in these cases.
Okay. Next, we have Dr. Samahir Al-Hussein, follow-up in asymptomatic pediatric patient who carry NF1 gene. I think the question is, what is the recommended follow-up for a patient?
Frequency of the surveillance.
Asymptomatic patient, known to have NF1 gene mutation.
We personally, it's usually annual, but I personally would recommend 6 monthly optic vision check and reviews of development. Just a general check every 6 months. If they remain asymptomatic after the age of 5, we'll say annual reviews should be okay. But all of my patients, for example, will know that if any of these red flags occur, they will need to come and arrange a sooner appointment to be seen. So you will not wait a year when you have headaches. You will not await for the next one if you develop a seizure or one of your neurofibromas started growing out of proportion. So they need to know the red flags. They need to know when to access services a bit earlier.
Okay, we have Hind Ahmed. She's asking about any role of MEK inhibitor.
So the sulimetinib is not licensed, and the new medications are not licensed for general NF. They've not been tried in the general population to see if they have a preventive role. And a lot of the parents would ask that question. It was like, if you have a medication that is treating and stopping these tumors and making them regress, can we not just take it? It's very expensive, and up to the moment, there is no role for them in the treatment of standard NF cases. For those with optic gliomas and for those with multiple tumors resistant to chemotherapy, even if it's not plexiform, we do have exceptions that we've tried it out of the license. But it's not for use in every case, and that will cause a lot of burden on the family and on the health services unnecessarily, especially with the high price it comes with.
Okay, we have this one question. Any specific consideration when NF patient present with intractable convulsion?
You'll treat same as you would treat your status epilepticus.
Okay.
And the majority of them, to be fair, they don't come with seizures. It's one of the rarer presentations in NF1. And usually by that time they would have a brain tumor. So your focus is on removing the cause of the seizures, and the control for seizures is the same as any status epilepticus.
Okay, we go to the next one, Dr. Saharbella. If I am general pediatrics, how to deal with the case of NF1? Can I refer him directly to genetic testing?
If you have the facility, yes, you can refer to genetic testing. Again, if you have a specialized service or a neurologist who's interested and able to perform the regular reviews and surveillances, then that should be it. If you're the general pediatrician and you have no other access, you would be expected to refer to ophthalmology to do the slit lamp examination, abdominal and pelvic ultrasound for the deeper organs, checking if there is any signs of neurofibromas. You will do bone age for those above 3. You would arrange for MRI scans depending on the facilities that you have and the child's position. So, like for the UK in the NHS, it's not intended to do an brain scan for all the cases of NF1. That is set like the facilities and the approach to the same health services for everyone. But if you are private setting where the parent able to afford, we say do one MRI brain scan as a baseline and then do reviews if there is something that is the scans. So you could arrange for diagnosis. You could refer to geneticists. You can do your screen and a detailed clinical exam. Refer for geneticist or genetic testing, saying that you're looking for NF1 gene, and they could advise. If the first one comes back negative, have still a high suspicion, it is look for the deletion duplication defects.
Okay, next we have question from Dr. Hadi. All the skin tumors of the nervous origin, can they
when I was in the US, the general pediatricians will not diagnose.
Dr. Hiba? Okay. Dr. Hiba, you are still with us?
Sorry, I lost you there for a sec. So all the nerves that come from the nerve sheath was the... Yes, can you hear? Can you hear me?
We can hear you. الصوت كان شوية interrupted. Your voice was interrupted. لكن we can hear you now. Okay, we will take the next question.
Okay. I just the question was about tumors.
A skin tumor of nervous origin, or can they come from the skin itself? From Dr. Abdelhadi.
The question.
The question was,
Yes,
is
they can come
the
from the
tumor
skin,
from the
peripheral
can it come
nerve.
from the yes, yeah, can they come from the skin, or it is always from the nerve?
It's the nerve sheath, so it's the fiber that covers the nerve tissue. But the tumors can present in the skin, which is the commonest place, but you can have neurofibromas internal organs. So you can have a neurofibroma, pheochromocytoma, a neuroblastoma. You can have all of these tumors that are linked to NF1, but they can appear either on the skin or like the peripheral nerve sheaths once, or they can be internal as well. And that's why having an ultrasound regularly every 6 months for the younger ones and every year can help in identifying these cases.
Okay. Next, Dr. Walid bin Hammam, is neurofibromatosis produce precocious puberty incomplete form in male?
A lot of my patients have presented with, can you hear me?
Yes,
Hello?
we can hear you. Go ahead.
Yeah. A lot of the patients that come to my clinic
we can hear you.
presented with short stature and signs of precocious puberty, either pubic hair or other features. And that made us think about research specifically to that area. And that's why we involved our endocrinologist early. And one of the recommendations that we've done, and it's unique to our clinic, is that we do the bone age early, because a lot of these cases will benefit from suppression of puberty. Some of them might have a tumor of the pituitary or in the optic chiasm that is affecting puberty and leading to precocious puberty. So it's a sign, sometimes very important to pick up as an emergency, and you can offer treatment to suppress puberty and give that children a bit more time to grow and be a bit taller. So it is very important for those coming for surveillance, yes.
Okay. Okay, so we go to the next question. This one from Anonymous, Zoom, calling himself Zoom user. He's asking, does all who carry genetic mutation will have the disease?
Yes.
Okay. Mom
Yes,
Ahmed,
yes,
there is
yes,
a place
yes.
for
there is a lot
okay.
of overlap with Noonan, Watson disease, and we didn't go into the details of the genetics. We thought we'll just go into the preliminary touching base on it. But a lot of them will have, all of them, the majority will have NF in one sort of form that are cross-linking in chromosome 17. So not every patient looks the same as the others, but some of them might look a little bit syndromic. And they might have some congenital heart disease, but that is, for example, linking them to Noonan.
Okay.
And those would be the ones who are
Dr.
more
Hiba, your voice is
intellectually
a little
impaired
bit
or have other difficulties.
your voice is a little bit weary. We are hearing interrupted. Can you hear us now?
Connection. I can hear you quite clearly.
Yes. Okay. Okay. So we have a couple of questions, around 6 questions. If there is a place for diagnosis if Caf'e-Au-Lait spots appear at birth and appears later after 6 years.
If it appears at birth and you have facilities, I would say go for genetic testing. Don't wait for the 6 years. Make every opportunity for you to see the patients, pick up those Caf'e-Au-Lait spots. They're only the most obvious signs. Other diseases might have Caf'e-Au-Lait spots as well. So doing the genetic test, if you can, the earlier possible is better. If you don't have genetic access to geneticists, they will have to be reviewed every 6 months to see for side effects, unfortunately, or other manifestations to confirm the diagnosis.
Okay.
An early diagnosis at birth helps you by being able to pick up, having that regular surveillance, offering support for the family, and better understanding of the child's needs. When you come at 6, if that's the first time you see the patient, then you've missed 6 years of intervention and of support. So the earlier you could pick up these cases, the better, and the better outcome for the children and their families.
Okay, so we have Dr. Samahir. She has 2 questions. The first one is, sulmitinib, is it available in Sudan? And the other question is, if the patient meets clinical criteria, do we need gene test, or just we can start the plan for multidisciplinary management?
I would answer the second one because that's the easy one. If they meet the clinical criteria without the genetic testing, start your surveillance. You don't need to. The genetic testing becomes more important for those where you are doubtful about the diagnosis. And if you are involved in research and you want to know the background of these communities, and you have good genetic counselors and labs that can give you that for a good price, why not? I'll do it for my own courtesy. But if you have a patient that meets the clinical criteria, then doing the surveillance, the genetic testing is not mandatory, and it becomes a luxury, if anything, for completion. You don't need to. You start your surveillance, you start your treatment irrespective. For sulmitinib in Sudan, sulmitinib, there is a branch for AstraZeneca in the Middle East and Northern Africa. It was available in Egypt. I'm not aware of any cases in Sudan up to that, my knowledge. And we've been in very regular contacts with AstraZeneca. And we've attended their meetings in Egypt, and they do have a group started there. I'm not sure it is available in Sudan, especially with the situation now, and it's very, very expensive. If I'm going to pay $20,000 for a month, and it needs 2 years at least to get to see the effect, I think maybe that money is better used for diverting to better facilities and better care.
Okay. So, Dr. Suad Ahmed, she's asking about this case. In case of what is the maximum age for the symptoms to appear? In the asymptomatic case, what is the maximum age you are expecting the symptoms to appear?
There is no maximum age.
Okay.
Every case, as we said, is different. I have children with severe malignancies, multiple malignancies at the age of 10 who were completely asymptomatic. We have adults who've reached their 20s and they've been discharged from pediatric services with no manifestation whatsoever. I have parents who are functioning as adults with no complications, but their children are presenting with side effects and complications. So there is no time where you will say, I'll stop seeing these patients, since they've not developed tumors up to the age of 20, or they didn't develop scoliosis up to this age, they will not develop it anymore. There is no such thing, unfortunately.
Okay. So we have 2, I think, 2 points. They are just trying to mention what you have talked about earlier. The first one is from an anonymous attendee. He's saying, I would like to share to answer the question for genetic testing. If you have the service, go for it, but negative test doesn't rule it out. However, diagnosis is usually based on clinical score system. If not fulfilling the criteria, then follow-up regular is crucial. You have any comment on this?
So we said 5% of the cases who are clinically meeting the criteria might have a negative genetic test. So if you have someone that meets the clinical criteria, you don't really need the genetic test. If you have someone who does not meet any of the clinical criteria and only presents with Caf'e-Au-Lait macules, and their genetic test is negative, this makes then NF1 very unlikely.
Okay. Dr. Hind Ahmed, she's also clarifying what we have said. Not all who have the mutation will manifest the disease of NF, as there is something called reduced penetrance.
It's an autosomal dominant. Every child's mutation is different. We have ongoing research about the phenotype-genotype correlation. And there is no clear correlation of which mutations present severely, which mutations present less. So there is no reduced. We do have few cases of mosaic, and usually those tend to be less severe than the rest of the cases, but there is no cutoff. There is no clear literature about the phenotype-genotype correlation. But and you can't tell, even within the same family, as we said, they have the same gene mutation, they carry the same problem. Their manifestations can be completely different to each other.
Okay.
So it's not something that you can say, if you have this gene mutation, then you're likely to have less severe disease, or you might have less penetrance, because it's an autosomal dominant condition. They will manifest, but their manifestation is different because of the virtue of the disease, not because of the gene defect. So the same gene defect can manifest differently.
Okay. We have
That's the answer.
Yeah, thank you very much for being with us and bearing with the questions. We have
no
Dr.
worries.
Abdul
A lot of some of the parents will come and say, I've had neurofibromatosis. I'm not impaired. I'm functioning. I'm working. I have no problems. I had children. I'm normal height. So most likely my kids will be the same, and there is no need for follow-up. And that's not the case, because that child, for example, came in with an optic glioma. So there is no guarantee if that is the case with the genetic testing.
Okay. So we have Dr. Abdul Rahim. He is asking how effective are targeted therapies like sulmetinib for plexiform neurofibromas in NF1. This is the first question. And if there is any genetic editing therapy?
The genetic editing is ongoing, as we said in our last slide. If you want, you can have a look at these. Let me see if I can go to the last slide, because every time you go back, you will hear more research is going about genetics and about gene therapy and targeted therapy. You can have a screenshot if you want from these and look it up. A lot of the cases are from the Chinese and Korean centers. They have thousands of patients, so they have more ability and more genetic testing to be able to make up something. But still, there is no much hope up till now for target genetic testing. The other question was about, sorry, I've...
Okay.
The first question from Dr. Abdurrahim, what was it about?
Yes. It was
how
about
effective is sulmetinib?
Yes, how effective it is.
So 90%, according to the SPRINT phase 2, have reduced PN volume from baseline. And that's quite significant reduction. We get to see in the cases that we've used sulmetinib, not necessarily a reduction in the size, but a stabilization on the size. So it stays as it is. It doesn't grow further. And we trial the patients for 2 years, and then we give them a break and see. And then in most of the cases would resume it, because if you've got a good medical insurance that covers the cost for the medication, there is no meaning of preventing these children then from it, especially when the side effects are minimal.
Okay.
So at least you'll get stability of the symptoms rather than regression of the signs.
And it will be lifelong. There is no
there is no limitation. Most of them will advise giving it for 2 years and then stopping. Remember, this is a medication that started in 2020. So by the time it got to the markets and everything, it was about 2022 when we first started using it in our hospital settings. So our experience, even as clinicians using it, is not the widest. That's why when we are going back, we go back for centers in China, and they have thousands and thousands of patients who've been on selumetinib. So a lot of patients that we see in literature are either from the States or from China.
Okay.
And we are just learning baby steps.
Okay. So we have 2 more questions. These are the 2 last questions. The first one is from Abu Muhammad. He's asking factors influencing outcome and prognosis.
I would say the factors are mainly your early detection. Some rare of the missense genetic mutations are linked with severe disease. And those are the ones that we tend to see developing tumors early, and those who are the ones that need to be closely monitored. But I think mainly you cannot predict. Early detection does help. Good support for the family and emotional support, more than anything, is very vital for these patients. It's a very costly disease to have, because you will need to see all of these different specialties, having all of these investigations regularly. And if finances are a problem, it makes your compliance less and your outcome even lesser.
Okay. So we have these questions from Yasi. Dr. Yasi, he is asking, he has a child with 2 spots at birth, Caf'e-Au-Lait, no more other feature. He consulted the neurology, assured at 9 years. He was assured at 9 years he developed Hashimoto thyroiditis with low thyroxine. So he's asking, do you think there is any link?
I honestly don't think so. If you looked at yourself, and if I go back and stand in front of the mirror, I'm sure I will find that I've had 2 or 3 Caf'e-Au-Lait molecules somewhere. It's very common, especially in our skin tones. I wouldn't have taken this as a sign. Regular checks for your thyroid at birth, the screening, the neonatal screening is important, but also the signs in the patient. You might develop a disease after birth. It's not something you are born with.
Okay.
Then
Okay.
I don't see the link.
Okay. I think that would be all with the questions. Thank you very much. There is a lot of gratefulness and thanking you for the elegant presentation. Some of people, they are saying this is a great presentation. It was very useful. So I think you achieve your objective. So Abdulaziz.
والله يا محمد يا اخي اول شيء برزنتيشن فيري نايس. نشكر دكتور هبه جزيلا
At
على
least
هذا.
if you've got a question in your exams about it, it's good.
Aywa. Last one thing before we go, just Dr. Faqih, he was asking about if you have any contact. So if he would like to contact you regarding any questions or patients with NF1 for further management or further discussion, can you give us a specific contact for you, or how you would like to be contacted, ya Dr. Hiba?
For the clinic, the referral comes via email, and I can give you my email. It's hiba.badri@dubaihealth.ae. So you can share it. It's fine. It's available for everyone. And I think even if you look it up in the internet, you will find it. But if you have any queries, you want to refer a patient, feel free to send your referral through the email and we can try and arrange it. If it's for consultations, again, you can send it to that, or for our fellow colleagues. My contact details are with the group. Feel free to share them with the attendees. I don't mind.
Okay, if you can write it in the chat box, your email and the way of the contact, so they can just take it.
Yeah, I prefer the emails when
email,
you
yes. Hiba,
yeah, when you go through WhatsApp, the amount of groups that we have, it becomes really difficult to promise to answer all the questions.
It's okay. Okay.
Sorry, my new keyboard is decided.
You can stop sharing it. Yeah, it appears now. hiba.bedri@yahoo.com.
Yeah, that's my personal one. On work for referrals. It's coming. Okay.
Okay. So thank you very much, Dr. Hiba, and it was very great and nice to have you and to have such a useful presentation. This will not be the last one, but this is the first one. Hopefully we can have you in another meetings also about the neurobehavioral and neurodevelopmental status in children and different discussions and different topics. Thank you very much. This has been me, Mohammed Karrar, in the Sudanese Academic Pediatric Platform. Dr. Abdulaziz Al-Safi, also he was organizing this, and Dr. Hatim خلف الكواليس, also he was doing this effort with our academic committee, Dr. Taha Ibrahim. He also sent his regards, and the presence of Prof. Sati. Thank you very much. And Dr. Hiba, if you have anything to add.
أنا مبسوطة شديد من البرنامج حق الليلة، حضور جميل وأسئلة جميلة، وإن شاء الله نكون قدرنا نفعنا بكم الناس يعني، وربنا يعينكم ويوفقكم ويجعله في ميزان حسناتكم إن شاء الله. Good luck for those in Sudan who are going through the hassle of the rotation. Hopefully it will go fine and it will be a nice memory. Inshallah. We'll meet further.
Thank you very much, and see you inshallah next Saturday with a new guest and new topic inshallah. Thank you.
Inshallah. Thank you.
Good.
Thank you very much.
Good night. Good night.